Hello, everyone. Thank you for being here, and thank you to our panelists for joining us tonight. And finally, thank you to Mahogany for that wonderful performance, which leads so nicely into what we are all going to talk about on this panel, which is improving health equity and access to care. So I'd love to start off with a question for each of you that you can each weigh in on. We've been talking about improving access to care and health equity for years, and yet there is still so much work that needs to be done. So I'd love to start by asking, what is the single biggest obstacle in your view that continues to stand in the way of that progress?
Well, I think, first of all, thanks so much for having me. I think for me, it's the understanding of what health is. Often we say that, healthcare is, a determinant of health, and it is. But what we know is that like 80% of what makes someone healthy are systemic issues. So, what neighborhood they live in, for a lot of us, it's, your zip code is a better determinant of how healthy you are than your genetic code. And so it's really putting together how, access to safe and affordable housing, how access to quality education, access to gainful employment with, great benefits, all of that actually matters, as well as access to quality healthcare with, culturally responsive healthcare professionals. All of that matters. And so I would really love for our policymakers to have a more holistic idea of what makes someone healthy. And it's not just about, prescribing a medication, which is something that, I kind of learned in medical school, and I had to unlearn that it's not just about taking out then my prescription pad, now writing an electronic prescription, but it's about really understanding what's going on in people's communities and what are the barriers to health for them.
Thank you so much. Adrelia?
Yes, so thank you again for having me and that question. And as I began to think about what Mahogany just shared with us in equity is a demand. And from the work that I do as heading the clinical trial patient diversity department within Merck and in ensuring that our clinical trials are representative by all patients, I began to think that we really have to shift from being equal to equity. And equity means that for every community, that means something different, that the needs are not equal from one community to the next. And when I think about access to information, and for some communities, access about clinical trials is very available, it's very easily accessible, but there are also communities that do not have that same access to just the information, let alone talk about the access to the treatment and the care. And so for me, it's really, how do we make sure that patients have the information that they need to be able to make those decisions about their health for them? And especially when it comes down to participating in a clinical trial, I think that is a very personal answer that needs to be only answered by that patient. And for me, the goal is to make sure that every patient in every community, especially in underserved, underrepresented patients, have access to the information for clinical trials and whether or not they would want to participate.
Ai-jen?
Yeah, just to build off of that, I would say that the fact that our country has never fully, as a country, invested in caregiving, the non-medicalized care that we need to live well in our families and in our communities, from childcare to paid family and medical leave to senior and disability care. It's fundamental infrastructure and needs that we all share. And we are a country that needs more care than ever before, as 10,000 boomers turn 65 every single day, and 10,000 babies are born. And without the kind of policies to support, we're one of the only countries in the world that has no paid family and medical leave program, which means that 1 in 4 moms goes back to work within 2 weeks of giving birth. And so I just think there's some basic policies and investments as a country that we need to make in our ability to take care of ourselves and the people we love. And if we do that, I think it could be transformative in overall health outcomes. I always say that good caregiving, access to good caregiving, is the best prevention.
Thank you so much. And I wanted to pick up on that because I've also heard you say that care is justice. I would love to ask first what exactly you mean by that, and second, how that fits into our discussion about health equity.
Well, the fact that I think that the failure to invest in these caregiving systems and programs is the biggest driver of inequality that nobody talks about. It is a huge part of our lives and in our economy, but because we haven't invested in affordable quality childcare or paid family medical leave, we have literally 2 weeks ago, new data came out, 105.6 million family caregivers, 33 million households in our country who are raising young children, and working parents and family caregivers having to make impossible choices between working to pay the bills or caring for the people they love. And the numbers are not adding up because the average cost of childcare is $10,000 a year. The average cost of a room in a nursing home is $100,000 per year. And 60% of American workers earn less than $60,000 per year. So the math isn't mathing. And then on the other side, so families can't afford to pay more for care. And then on the other side, you have a workforce that can't afford to earn less. Care workers are working in notoriously undervalued jobs. The median income of a home health care worker in the US is $22,000 per year. Where can you afford to live and raise a family on $22,000 per year? So we have high rates of turnover, and by the way, the workforce is more than 80% women and majority women of color, and always has been. And so this is actually the biggest opportunity we have to not only improve health outcomes, but to address inequality and inequity in our country by investing in care, making care jobs good living wage jobs with real benefits and the ability for one generation to do better than the next, making care more affordable so people can actually stay in the workforce and sustain in the workforce as parents and as family caregivers. It's about a kind of economic investment that's an enabler for everything else, but also about addressing the inequalities, the inequities in who's been disproportionately holding the responsibility of care for our families and communities absent those investments.
Can I say something?
Absolutely.
That just made me think? The Commonwealth Fund came out with a study a few weeks ago around maternal mortality. And as many of you may know, United States, we have the highest maternal mortality rate of any of our peer high-income nations, even higher than some middle-income nations. And it's not just for Black women or women of color, it's for every racial and ethnic demographic group. But one thing that the study talked about was really, it was the lack of postpartum support, so that caregiving in the postpartum period for people who give birth that is just absent in our country, and that actually 2/3 of the deaths, maternal mortality deaths, occur in the postpartum period. And so that's really when people need the most support. I'm sure many people in this room have been home with small babies. It is a lot of work. You need a village, you need as much support as possible, but you also need a system that's going to make sure that you are not only psychologically okay, but you're physically okay.
And just one more thought on that from the standpoint of clinical trials, and where the FDA has charged the pharma industry to ensure that we have representation in our clinical trials. And in thinking about those patients in underserved, underrepresented communities, really don't have the transportation, don't have adequate meals, adequate funding to go to and from childcare, but we need those patients. We need all patients that volunteer to participate in clinical trials, and especially for that demographic, for those patients, if they participate in a clinical trial, they can only receive $600 for their time and effort, until that income has to be reported to the IRS. And so that's why I say from a social justice standpoint, we definitely need policymakers to support the Clinical Trial Modernization Act to help patients, especially the patients that we are trying to include, to make sure we have representation and the patient population that will show that the drug works for everyone is included in trials. So from that standpoint, we really do, it is a social justice issue, and we do need policymakers to help us to remove that gap.
Thank you so much for all of those comments. Dr. Blackstock, I wanted to go back to you because you take such an interesting perspective to your work at advancing health equity, given that you began your career as a practicing physician. What would you tell somebody who's not a physician? What might they not know about the daily realities of practicing medicine and how some of these inequalities show up in that practice?
Sure, and for me, it's been a journey. I think I started sharing with you in the green room, but there's a lot of unlearning and relearning that I had to do. There's a lot that I didn't learn in my formal education. So I am second-generation Black woman physician, which is something that is still very rare to say. Less than 3% of all physicians are Black women. My mother and my twin sister and I are the first Black mother-daughter legacy graduates from Harvard Medical School. And while I think that is wonderful, there's only like one other one after us. But also, what I learned in school and what I saw in my clinical practice were very, very different. I was trying to understand, especially when I was doing my emergency medicine residency in a public hospital in Brooklyn, why were my patients so sick? Why were people coming in with late-stage cancer? Why were they coming in with uncontrolled diabetes or uncontrolled high blood pressure? And it wasn't a matter of them not really, taking care of themselves. It really was a matter of them coming from communities that had been under-resourced, that had been redlined. We also talk about this issue, especially as relates to clinical trials, of like medical mistrust. And I don't like to use that term. I actually use the term institutional untrustworthiness. Because I feel like health organizations really have never really proven themselves trustworthy to marginalized communities, and it really takes a lot of intentionality to center communities and their needs, so that when, for example, a pandemic hits and we need people to get vaccinated, they're not like, wait, why should I get vaccinated, and who are you, and why? It's because we've been investing and building those relationships for a long time. So these are things that I wish I learned in medical school. I didn't recognize until I was a practicing physician. And I think the other thing I wish more health professionals understood was that when you're in your room with your patient, it's more than just you and your patient. It's their employer, it's their family, it's their community. And not saying that every health professional needs to understand all of the issues that their patients are facing, but we should have an understanding of how social and economic policies may shape the lives that they live, and what we need to do to connect them with the resources that they need.
Absolutely. And it also strikes me that the clinical trial data is in the room with them, and whether that serves them or not. So you've spoken really eloquently about some of the challenges facing clinical trial diversity, but I'd love to ask what you feel success actually looks like.
Very, very good question. I think, as we're on this, and it's a journey, it's not easy for us to be able to remove the years of inequity and the twinkling of an eye, but we are beginning to really see the first forward planning and making sure that we are intentional about being inclusive in our practices for clinical trials. And that involves the research sites that we're going to, making sure that we are going to geographies where those patients live, and that we are interested in enrolling in those diverse patient populations. And also looking at, so how can we make sure that we include the patient's voice? And as I think about this, it is focusing on patients, partnerships, and producing the results. And with the patients and including them in protocol design, what have we learned from insights? How do they want to receive the information about a clinical trial? And I think that's ensuring that our people are culturally competent in speaking to different cultures and making sure our research sites have that cultural sensitivity also, and promoting the education of our research sites so that they have a diversity of staff that represents the communities that they're serving, so that when those patients come, they can see someone that looks just like them. And as we begin to really keep the patient at the center of what we're doing and focusing on those partnerships, pharma can't do this all alone. And so what we have been doing is really collaborating as one pharmaceutical industry focus on the efforts of making our clinical trials diverse and really working in areas to build infrastructure, working with different schools focusing on the historically Black medical schools and how can we help support infrastructure build in the communities that already have trust with those particular patients, and then also working with partners that are engaging, community engagement, which has really become a really critical, essential act that we have to do that we haven't done before. And it goes back to talking about clinical trials. Before the pandemic, no one ever had the discussion about what a clinical trial is, what were some of the social injustices that happened before, and how can we now sit down at the table with those communities to talk about the diseases that impact their community and how we can all work together to design a clinical trial that really will help the patients in their community. One last thing I would like to also address when I talked about cultural competency, we really do have to put a lot of effort in training and working with our research sites because they are the face of the clinical trial in the community. And one of those areas is really unconscious bias and making sure that, you know, our research sites, we all have it, but recognizing when you're working with patients from a different cultural background that we remove those biases and or at least acknowledge that you have them so it doesn't impede on the patient not receiving the information that they need to better their lives. So we have seen some progress even in some of the therapeutic areas. I will say out loud, oncology is the area that many of us struggle in. And it is one of the areas where the scientific advancements that we have now, we have to really work very hard to make sure that we bridge that gap because it is a matter of life and death for some patients.
Absolutely. And Ai-jen, I want to go to you as we talk about striving for success. You are really an organizer and an activist at heart. How can we apply some of the principles of organizing work to this fight for health equity?
Well, great organizing has as its heart storytelling, great storytelling. And I do believe that there is no greater way for us to connect to one another and to connect to the issues and solutions that matter than by sharing our personal stories. At Caring Across Generations, at the beginning of every meeting, we take a few minutes and turn to the person sitting next to us and share a story about someone in our lives who has cared for us or someone that we're caring for and the meaning of that relationship in our lives. And there's not a single room that I've been in more than 12 years that doesn't light up with a sense of warmth and connection. And it creates a whole different context for the conversation about policy and solutions, which can get very wonky very quickly, but to anchor it in the actual human story, the human experience, and the human relationships that are at the heart of any policy success is what I would say.
Thank you. And we have just a few minutes left here, so I want to end on a positive note. I began by asking you about the biggest challenge facing the fight for health equity. I would love to end by asking, what is the best example of progress or hope or optimism that you've seen recently?
So I'm not sure if folks saw this today, but in the New York Times, there was an article about a 12-year-old who received gene therapy for sickle cell disease. And some of you may know sickle cell disease has been a disease that's been around for was described over 100 years ago, but because it's been racialized as a Black disease in this country, it hasn't received the funding and attention it's needed, and hasn't received as many treatments as other inherited diseases. But this child, essentially, even though they went through a very difficult process going through the treatment, essentially is cured from sickle cell disease. So it really is essentially life-changing. You know, because I am a health equity advocate, I always have to think about, you know, issues of accessibility though. So I want to make sure that we're thinking about, and our policymakers are aware of like what is needed to undergo this treatment, what is needed to be able to afford this treatment, making sure that it's accessible to the folks who it disproportionately impacts. So I think there is a lot of great you know, great therapies on the horizon. We just want to make sure that everyone who needs it gets it.
And I'll say for the area of clinical trial patient diversity, we're now having to ensure that we have a plan in place. And so it's not, you know, continuing the perpetual, you know, we didn't achieve diversity, but now with the diversity action plans that we're pending the finalization of the FDA to provide their guidance, we know that we will and are charged to have a plan in place to ensure that we'll have diverse patients in our trial. And so I think with this requirement, we will eventually see where representation is included in our clinical trials, and with the importance of community engagement, where, you know, talking about a clinical trial will not be a myth. Everyone will know what a clinical trial is. They will even know in their community where they can go and get the information that they need. So we're on the cusp of being able to see that become reality.
And Ai-jen?
Yeah, so coming out of COVID, I feel like we are finally having the conversation about caregiving in this country that is so long overdue. We have started to talk about care work as essential work. We have started to talk about the need for caregiving solutions at the policy level, as opposed to just thinking about it as a crisis of personal failures, like I didn't buy the long-term care insurance, I don't have the right job, right? We're starting to realize that we can be doing everything right, and without infrastructure and systems and a strong workforce, it is simply not enough. So we're seeing incredible policy conversations about everything from investing in Medicaid, home and community-based services in a way that both expands access to those services and strengthens the workforce, to new ideas like having Medicare pay for home care would be a game changer, to allow for the people, literally the millions of us who have aging loved ones, to be able to keep them at home, care for them at home, and be able to afford to do that and work at the same time. So I believe that we are the generation that is going to transform our ability to care for the people that we love in this country for future generations to come.
What a lovely, hopeful note to end on. Thank you all so much for being here.
Thank you.